All right, party people, we are back at it with another one. Let's get it. If I was to give you a 15-year-old male with 24 hours of epistaxis, normal vitals, a hemoglobin of 14, and a hematocrit of 40, white blood cell count 6,000, as well as a normal blood smear, and ask you which of the following is associated with this condition, which would you choose? 3, 2, 1. Boom. Glycoprotein 2B3A. Let's get into why this answer is correct and why the incorrects are incorrect. So for starters, the patient's hemoglobin is within a normal range, which is 13 to 17.5. The hematocrit of 40 is also fine. 47 plus 5 minus 5 is normal for males, and 42 plus 5 minus 5 is normal for females. He has epistaxis, and this might explain why his hemoglobin is on the lower end of normal. Hematocrit is also at the lower end, but still within range. Nothing to be too concerned about. His white blood cell count is also normal at 6,000, where the normal range is 4,000 to 11,000. So what exactly is the problem here? You have a 15-year-old with a nosebleed and a normal smear. Could it just be incidental? A lot of the times it could be. But if you have a patient like this, where everything more or less seems to be normal, except for epistaxis, and it could be incidental, but they're forcing you to choose a pathology, the answer for this is ITP, immune or idiopathic thrombocytopenic purpura. The mechanism involves antibodies against glycoprotein 2B3A on platelets, which mediate platelet aggregation. In other words, this is the platelets sticking to each other. Glycoprotein 1B is involved with platelet adhesion. This is to collagen under the endothelium. Adhesion is mediated by von Willebrand factor. This links glycoprotein 1B to collagen. Aggregation, on the other hand, is facilitated by fibrinogen linking glycoprotein 2B3A between platelets. Now, ITP often follows viral infections, but they don't always have to verbalize the infection that took place. A lot of times it can just be implied. They don't even have to tell you about it. So they may not tell you that the child had a recent cold or a cough or he was feeling under the weather, but the answer is still ITP. Many viral infections are asymptomatic, so that's not unusual. So in the sequence of events, here's how ITP goes down. Antibodies that are produced in response to a virus cross-react with platelet glycoprotein. This is due to molecular mimicry. This is a type 2 hypersensitivity reaction. This results in thrombocytopenia. You diagnose ITP based on platelet count. This will be low, typically under 150,000. And it could often be under 100,000. Bleeding time will also be increased. This is above 7 minutes. Please know, normal is 2 to 7 minutes. If you're forced to choose between platelet count and bleeding time as the diagnostic test to discern this, you choose platelet count. Now, most ITP questions will involve school-aged children, someone who recently had a viral infection and now is showing epistaxis, petechia, or bruising. These are platelet-type bleeding problems. They're usually minor or cutaneous. This is opposed to clotting factor deficiencies, by contrast, which are much more severe, such as excessive bleeding after dental procedures, menorrhagia, hemarthrosis, and hemophilia. And the rest of those questions on the exam will show you a woman in her 30s or 40s with random bruising. If her platelet count is low and bleeding time is elevated, that is ITP. But if both are normal, you have to know that this is domestic abuse. The point is, if labs are normal, do not pick ITP. If labs are abnormal, then you can rock with it. Now, you also have to know that there's no strict inheritance pattern for ITP, but there are familial tendencies. Let's run through the incorrects to see why they are incorrect. So, beginning with alpha hemoglobin, this is alpha thalassemia. If you have one mutation, you're a silent carrier and asymptomatic. If you have two mutations, you have alpha thalassemia trait, resulting in mild anemia. If you have 3 mutations, this is hemoglobin H, and you will be very sick. If you have 4 mutations, this is known as hemoglobin Bartz. Hemoglobin Bartz will give you gamma tetramers. This leads to hydrops fetalis, usually fatal in utero. All right, next up, we have hereditary spherocytosis. This is caused by defects in ankyrin, spectrin, or band 3 proteins. These are all members of the RBC cytoskeleton. Cells are spherical, they lack that central pallor, and have an increased MCHC. To diagnose this, you use osmotic fragility test or the more recent eosin 5 malamide test. Hereditary spherocytosis is inherited via autosomal dominant pattern. Classically, what you will see, they give you a child with anemia and a father who had his spleen removed for a quote-unquote blood disorder. They're pointing you towards the repeated infarcts of that spleen that needed to be removed. The removal usually takes place in the teenage years. So for beta thalassemia, it's an issue with beta hemoglobin. Beta hemoglobin mutations give you beta thalassemia. If you have 1 mutation, this is minor, usually asymptomatic, resulting in mild anemia. 2 mutations result in major severe anemia in infancy with extramedullary hematopoiesis. This will give you things like the chipmunk facies and an elevated hemoglobin A2, alpha 2, delta 2 as a diagnostic clue. Now, popping back over to ITP for a moment, just understand that the first line treatment is steroids. If the patient is unresponsive to steroids, you give IVIG. And if they are still unresponsive, then you do a splenectomy. Now, moving on to von Willebrand disease. This is inherited via autosomal dominant pattern. This presents in a teenage girl with epistaxis and menorrhagia. You'll see an elevated bleeding time and PTT. Just know that for USMLE, if you know the inheritance patterns, that will make your life easier. Because, for example, if they give you a girl with a bleeding disorder, you can immediately rule out hemophilia A or B because they are X-linked recessive. And just to summarize, for ITP, you're going to have autoantibodies targeting glycoprotein 2B3A. About 75% of cases, school-aged child will present with a post-viral nosebleed with petechia. The remaining cases, you'll have an adult woman with bruising. You have to diagnose this with low platelet count. You treat with steroids, followed by IVIG, followed by splenectomy, and the smear will be normal, even in an active disease. All right, that's it for this one. Go crush it.